Hello everyone, good evening. Welcome aboard. Looks like many of you have joined in. All right, so as you all know, we are going to start our Pharmacology 25 most important topic session. So a couple of things before we start here, doctors. I will try my best to keep this session as crisp as possible so that you guys don't have to waste too much time here. Right? We will just hammer the most important aspects that you need to know for sure. So this is the time where I don't want you to think too many whys, like why this is happening, right? This is not the correct time. As you know, the exam is near. We would want these main facts to be in our head, right? So whatever the queries, if you have as such, please message me later. I will definitely try to clarify them as much as possible. So for now, we will just go ahead with what you need to know. All right. So I hope that's clear enough to everyone. So without further ado, let's begin. This is our first question. A 35-year-old male purchased a Royal Enfield and under peer pressure of his colleagues planned to go to Ladakh. All excited, they ascend to 2,600 meters above sea level rapidly. Many of them feel dizziness, headache, muscle aches, insomnia, swelling of the hands, feet, and face, rapid heartbeat, etc. What medication would be prescribed for them? All right. So looks like you guys are all set. Already I'm receiving the answers. First of all, what exactly is the diagnosis? I hope you guys have made it. The diagnosis of this topic is none other than our mountain sickness, right? So what are the hints that told us that this is mountain sickness? Number one, what is a typical story? Like if you buy Royal Enfield, you have to go to Ladakh. Yes or no? That means they're talking about mountains. So this is mountain sickness. Yes or no? Next, second thing, they have already given the height and everything. So straightforward, they have given you the diagnosis. See, this is what is going to happen in our questions. Like the same thing which you know in one line known as mountain sickness will now be described in few lines with some extra, words as such. So as we may know, mountain sickness, the drug of choice is acetazolamide. Although all of these are diuretics, then why exactly acetazolamide is the only one I can use in mountain sickness? See, the answer to this is acetazolamide has one side effect, and actually that side effect is being used in the treatment, right? So let's look here. What is the side effect of acetazolamide? Let's all by heart from this first three letter. It produces acidosis, right? So acetazolamide side effect is it is producing acidosis. And guys, this acidosis will actually help you treat alkalosis. Okay, this helps you treat alkalosis. And what is the example of this alkalotic condition here? The answer is mountain sickness. So mountain sickness comes under the diseases called as alkalotic conditions. So to neutralize that alkalosis, we need to produce acidosis, and the diuretic that is producing acidosis is acetazolamide, the drug of choice for mountain sickness. Okay. Now, I'm going to discuss about diuretics once we solve one more MCQ. Okay. So, I just pray that you guys pass the exam and you guys go on a trip to Ladakh as usual on your Royal Enfields. Now, guys, let's go ahead. Next MCQ. A 42-year-old man with history of alcohol abuse has edema, demonstrated by shifting dullness. Spider nevi are also noted. Paracenteses show clear fluid. Which of the following drugs is preferred in the condition given in the picture? Okay, so there you go. You guys are rocking this already. I'm sure you have diagnosed that this is nothing but ascites. As you can see, ascites, we can figure out most likely this person is having cirrhosis. And you guys should know that in the serotic edema, the drug of choice is spironolactone, right? The correct answer for this is going to be spironolactone because that's the drug of choice for serotic edema. All right, so I hope this is clear enough to all of you, right? So good enough. That's what you needed to know. As I said, let's now discuss about diuretics. So what are a couple of things that you needed to know as such with diuretics? Let's see here. Now, the whole concept of diuretics, doctors, is this, that is, imagine this is our kidneys which have urine, and just along that, nephron, there are some blood vessels called as vasa recta. So what is the purpose of having this blood vessel? Whatever your kidney feels is important for your body, it will not allow it to go through the urine. Are you getting what I'm saying? Whatever is in the urine, if your body feels it's important for your body, it is not going to make you lose that. Rather, it will get it back into the body. And while it is getting some things back, this process is called as reabsorption, right? Basically, from the urine, the things coming back to the blood, it's called as reabsorption. Now, this reabsorption is happening in various parts of our nephron. Okay, it is happening in PCT also, it's happening in loop of Henle also, it's happening in collecting duct also, it's happening in distal convoluted tubule also. So technically things are coming back into our blood, and the most precious thing to our body, especially to our kidney, is sodium. It does not want to lose sodium. Sodium is followed by water, as you can see here, doctors. Sodium is followed by water. So technically we are all made up of 65 to 70% of water. That means our body does not want to lose sodium. So what is happening basically is, anytime in our nephron things are coming back like this. So if you don't want sodium to come back into the body, what we will do by giving diuretics drugs is we will block this reabsorption. If you block reabsorption, sodium and water will be lost now. Basically your body is losing volume. Right? Now the question should be asked, why do I want to lose volume? It may be excess in the body, right? What are the scenarios where it can be excess? Example, edemas. In edemas, I want to lose volume. Now, depending on where my diuretics work, they have different names, right? Some diuretics work in the PCT. They block sodium from coming back from the PCT. Some work in the loop of Henle, some work in the collecting duct, some work in the DCT. Like that, there are multiple diuretics. Now, once you have figured like what I said, now let's pay attention to one more point. Almost all diuretics, apart from sodium, as a side effect, they will also lose potassium in the urine. I repeat, all diuretics, they will lose what? They will lose potassium also as a side effect, right? Except one class of diuretics, potassium sparing diuretic. Look at their name. Their name itself is saying they save potassium. That's why they're called as potassium sparing diuretics. Remaining all, they lose potassium. Potassium sparing, they save potassium. And those drugs, potassium sparing, they work in the collecting duct. Okay, potassium sparing diuretics, they work in the collecting duct. Now with this basic knowledge, what I have done is for you guys to quickly revise things as such in one place. See, one chart as such I have made for all diuretics topic as such. Okay, तो अब अपने को क्या समझना है? We have to see which diuretics work where, what are their main uses, etc. Right? So this chart is going to be for your revision. I can't discuss the entire chart right now. Okay, so first things, in the proximal convoluted tubule, there are two diuretics that will work. One is carbonic anhydrase inhibitor, second is osmotic diuretic. Okay, I repeat, in the PCT, carbonic anhydrase, and second one, what we know is osmotic. Okay, so example of carbonic is what we just studied, acetazolamide. Acetazolamide basically is used in couple of things, as you can see here. I have given it by the mnemonic game. Second things you should know, that this drug is producing acidosis, as I told you. And why does it produce acidosis? That also the reason is written. It makes you lose alkali from the body. If you lose alkali from the body, your body will become what? Acidotic, right? So that's your mnemonic. Acetazolamide acidosis karta hai, right? So that's what you need to know. Next, the all famous loop of Henle. Loop of Henle, obviously loop diuretics will work here. The most strongest diuretics are loop diuretics. Most important example would be furosemide. Okay, furosemide will be our main example. Now, what you need to know as such is this: furosemide is the drug of choice for pulmonary edema, right? So this is the drug of choice for pulmonary edema. Now, as I told you, sodium, potassium, to every diuretic will lose, but there are some extra things that can be lost by loops. So we have to remember something, that loops lose everything. It loses sodium, potassium, calcium, magnesium, right? It's losing so many things. So we just say one statement that loops lose everything. And apart from this, there are some extra effects also. Please know that loop diuretics are ototoxic drugs. The most ototoxic drug from this list is ethacrinic acid. That itself can be your MCQ. Ethacrinic acid, this is the most, ototoxic drug from this category. Next, doctors, let's move to DCT. DCT is the place where thiazide diuretics work. Thiazide diuretics are those diuretics that mainly are used in hypertension. Okay, we mainly use them in hypertension. Now, unlike the loops that lose calcium, thiazides will save calcium, right? Thiazides are causing hypercalcemia. That means they will save calcium. That's what you need to know. Okay. Last and the final one or two things. Please notice, collecting duct mein we have the drugs called as aldosterone blockers and ENaC blockers. Together, both of these guys are called as potassium sparing diuretics. Potassium sparing are of two types: aldosterone blockers and ENaC blockers. Now you have to imagine that you're asking potassium to stay in the body. ठीक है? What do you say if you want somebody to stay? We say, please have a seat. Yes or no? If you want somebody to say, we say, please have a seat. So technically, seat is the mnemonic because we want the potassium to stay. These are potassium sparing. So these are the examples right here. Now from this, spironolactone definitely is very, very important. Spironolactone is the drug of choice for three scenarios: Conn's syndrome, serotic edema, the previous MCQ we had, and resistant hypertension. Resistant hypertension. And finally speaking, osmotic diuretic called as mannitol is the drug of choice for cerebral edema. So cerebral edema, drug of choice is mannitol. Pulmonary edema, it is furosemide. Serotic edema, it is spironolactone. Okay, so that's that. These are the main uses of our diuretics. Now, once we are done, let's move on to our next MCQ. So on starting a medication, certain changes are seen on ECG as shown in the picture. What drug might be the probable cause of this? I hope you guys have already noticed what is the difference between the normal ECG versus the patient. If you have figured that out, then that means the answer must be already in your hand. Okay, so I've given you the time for you to think. So now let's begin, doctors. Let's go ahead. First of all, just notice, you all know that this is P wave, this is Q, R, S, and this is T. We know that P wave is the guy related to atria, and this part of the graph or ECG is related to ventricle. If you notice, Q is the place from where ventricular action begins and T is the place where the end of ventricular action is seen. That means contraction and relaxation, depolarization and repolarization, right? That's what is seen between these 2 points, that is Q till T. Now, if you notice in the patient, the QT segment is prolonged, right? That QT segment is prolonged as such, as you can see here. So QT prolongation on ECG, this is the manifestation of one arrhythmia by the name of torsades. Okay, so QT prolongation is nothing but our arrhythmia called as torsades. And unfortunately, as we all know, that anti-arrhythmic drugs itself can cause arrhythmia called as torsades. Now you have to know in examination which drugs can do this. See, first of all, you should know the concept. Don't just mug up things like that. First point is, if any drug block potassium channels on heart, okay, if a drug blocks potassium channels on heart, that drug can cause torsades, irrespective that drug is from the chapter of arrhythmia or not. Does not matter. As long as it blocks potassium channel, that guy can cause torsades. And you should learn and memorize now which class can actually do this. One, class 3 antiarrhythmics can do this, which is the correct answer in this. Because what are the class 3 drugs? They are potassium channel blockers. Okay. And then even one more guy called as class 1A can do that. So class 1A and class 3, both of them can do that. All right. So 2 drugs from our chapter can do it, class 3 and class 1A. Okay. Now, if you are comfortable enough with this, yes, as you guys are going in advance, the treatment of torsades, if it happens, this arrhythmia is treated by the drug called as magnesium sulfate. Okay, magnesium sulfate is the treatment for torsades, and the mechanism is unknown. We don't know how exactly this works, but it works. Okay, so some places are there in pharma where the mechanisms are unclear. Now, this being said, your first priority in the arrhythmia chapter should be to remember what are the 4 classes of antiarrhythmics. If you're thorough, then this can be easy answer, right? For that only, I usually give this mnemonic. There are 4 classes, 1, 2, 3, 4. These are main. There is 5th one, which is miscellaneous. Miscellaneous means random, right? So let's leave miscellaneous apart. Let's look at the 4 main classes. First one is called sodium channel blockers. Second one is beta blockers. Third one is potassium channel blockers. And fourth one is calcium channel blockers. So 4 classes of drugs, as you can see here. And hope you guys remember from our classes also. So beautiful Priyanka Chopra. That's how we remember the 4 classes, right? So beautiful Priyanka Chopra. So if you memorize this mnemonic, you know the 4 classes of antiarrhythmics. So obviously, if you know class 3 is potassium channel blocker, and we said potassium channel blockers can cause what? They will cause torsades. So that's clear. Up the question comes, sir, how come sodium channel blocker is doing that? You just said potassium channel is doing. See, class 1 called sodium channel is further divided into 3 subtypes. They are called as class 1A, class 1B, and class 1C. So there are 3 classes, class 1A, class 1B, and class 1C. Class 1A, apart from blocking sodium, they have extra effect. And what is their extra effect? They block potassium also. So class 1A, they block potassium also, and for that reason, they cause this arrhythmia called as torsades. Okay. So I hope you guys are comfortable enough as such that you need to know. Okay. Chaliye. Now let's learn some drugs that can cause torsades. Okay. I'm sure you guys agree that having abs is cute. Okay, we will remember having abs is cute. This is the trend as such in this generation, right? So we will remember QT prolongation के लिए I am pro abs. That means, cute. So what is this? Prokinetic drugs. Example, tegaserod or cisapride. Prokinetic means these drugs increase the motility in our GIT. They might be used in a disease like GERD. Okay, because these drugs cause QT prolongation, of course, we are not going to use them. Next, A, B, and S. A is antiarrhythmics, class 1A and class 3, as I told you. Some antihistaminic drugs can do that, astimazole and terfenadine. Antibiotics can do that. Example, fluoroquinolones, macrolides. Fluoroquinolones are those drugs that end with fluoxetine. Macrolides are those drugs that end generally with romycin. Example, azithromycin, erythromycin. These are the ones that you need to know. And some antipsychotics can also do that. Okay? So as I said, we have to mug up these things temporarily until exam, and you may forget this as of now, right? So as I said, pro abs, right? Cute. That's the word, QT prolongation. Next question coming up on your screen. A 63-year-old man with a history of chronic hypertension, coronary artery disease, and a heart attack 3 years ago presented with shortness of breath, fatigue, edema in feet, irregular heartbeat, persistent cough, and wheezing with whitish pink blood-tinged phlegm. Echocardiography shows ejection fraction of 38%. BNP and PCWP were also elevated. Which of the following would decrease mortality in this patient? All right, guys. I hope you guys are ready with your answers. Please start typing in. Okay. Again, the whole idea of preparing this kind of questions is to get you oriented, right? So pharma questions can be integrated with medicines and the other clinical subjects. So as long as you know the basics from those subjects, then final link, if it's pharma, you can definitely answer. See, I'm sure by all these things being mentioned, especially ejection fraction of 38%, you guys have already figured they're talking about heart failure. And as of now, from this list, the best drug to be used is carvedilol. Okay, carvedilol. This is the drug that can decrease mortality. And when I'm saying the drugs that decrease mortality, these are the drugs we use in chronic CHF, right? These are the drugs we use in chronic CHF. Some drugs from chronic CHF, they can decrease mortality or they can increase survival in the patient. These drugs, apart from this option, you have to know that they're only used in acute heart failure. And as a matter of fact, acute CHF, if they mention, then the drug of choice is dobutamine, right? What does dobutamine do and what is heart failure? Heart failure is that condition where the pumping ability of the heart has decreased, right? So the force has to be increased by giving some medication. Increasing the force of contraction in the heart is called as inotropy, right? So who is the inotrope that we prefer in CHF treatment? Answer is dobutamine. Dobutamine is the drug of choice as such. Usually speaking, along with acute CHF, pulmonary edema comes, and to treat pulmonary edema, we add which other drug? Furosemide. Each drug has a different purpose. Milrinone is also a inotrope, but it's not the drug of choice. Drug of choice would be dobutamine. So from this list, 3 drugs were from acute CHF. The only drug which is from the chronic is carvedilol, the beta blockers. All right. So correct answer, just for your clarity, it is carvedilol. Although in acute CHF, the drug of choice, the answer would have been dobutamine. Okay. So hope this is clear enough. ठीक है. acute CHF में the drugs what we use, they're not going to increase survival or they will not decrease mortality. ठीक है? The drugs we use in management of chronic CHF, they will decrease mortality. And which is the drug from this which is used in that list? Carvedilol. So correct answer is carvedilol. Okay. Now, we may have learned that CHF is also called as broken heart syndrome. Okay. And many of you must have already had it. Okay. This is our scenario that reminds of that Channa Mereya, right? So this guy is having that heart failure. Now, in the Bollywood industry, I'm sure you guys know one guy is known for his heart failures. He never got a good chance. And next to that, there is somebody, I don't know who that is, but that guy did not have heart failures. Don't worry. All right. So let's learn now what are the drugs? What are the drugs that decrease mortality? So guys, let's just remember the point is heart failure mein let's remember our Sallu bhai from the Bollywood. Salman Bhai Saab, right? Let's remember this thing. What are the drugs that decrease mortality? So first of all, let me write down here a drug by the name of sacubitril. Okay, a drug by the name of sacubitril. This is the first thing. Next, beta blockers. Beta blockers, as you see here, beta blockers are the other one. Hydralazine plus nitrates. This is a nitrate drug. Isosorbide dinitrate. Okay. As you can see, the other drugs we all know, ACE inhibitors or ARBs. These drugs, prils or sartans, they are also used. Next, last one, ivabradine and spironolactone. See, you all need to understand one basic thing here. What is the aim of treatment in a CHF which can decrease mortality? So let's remember the aim of the treatment here is basically to decrease workload on heart. We want to decrease workload on heart. For example, ivabradine. Look at the word bradycardia is there in the name of drug. If you decrease heart rate, obviously the heart doesn't have to work too much. That means the workload will decrease. Workload will decrease. So that's why this drug is used in the chronic CHF patients. Okay. So this is the thing that you need to understand. As you can see, the other things as such, what you have here, spironolactone, etc., etc. Many of the drugs that block RAS. Let's just remember the final outcome. RAS blockers. Okay. RAS blockers are those drugs basically that can decrease the workload. And as you can see, RAS blockers like beta blockers, spironolactone or ACEs or ARBs, these are all there in our list. These are all there in our list. Okay? So RAS blockers are pretty much the ones that we use here. Now, last and the final, let me address one last point and we will go ahead, doctors. Sacubitril. Sacubitril is usually combined with one more drug. I'm just writing a short form here for sacubitril. Sacubitril is combined with something called as valsartan. This is a fixed combination you should know in heart failure, right? Basically sacubitril along with what? Basically valsartan. You need to know something. This combination is called as ARNI. Okay? This combination we call it as what? ARNI. So what exactly is ARNI you need to know? See, valsartan is a sartan. Sartans are what drugs? They are angiotensin receptor inhibitors. So the AR stands for angiotensin receptor inhibitor. I stands for inhibitor. N stands for neprilysin inhibitor. And the neprilysin inhibitor from this list is sacubitril. Sacubitril is neprilysin inhibitor and valsartan is what? Angiotensin receptor inhibitor. So these are the drugs that you needed to know as such in the chronic CHF. Okay. So I hope you guys are comfortable with this. Next. All right. So what could be the possible side effects of the drug that makes the following changes in the patient's body? So first of all, from this graph, you have to figure out like what drug it is. Then you have to know what are the side effects of that drug. Okay. Now, as you can see, renin seems to be increased, angiotensin 1 seems to be increased, but angiotensin 2, aldosterone is all decreased. See, first of all, do you all remember that conversion of angiotensin 1 to angiotensin 2, it's happening by one enzyme called as ACE. ACE converts angiotensin 1 to angiotensin 2. So if you have given a drug called as ACE inhibitor, that means the things before the block would increase. In the RAS system, the things before the block would increase and the things after the block would decrease. Okay. And we said as a side effect, one thing ACE inhibitors can do is they increase bradykinin. ACE inhibitor drugs, they increase bradykinin, and this increase in bradykinin can lead to two things. What are the two things by this? One is dry cough, right? One thing is dry cough. It's not wet cough. So please be attentive. I hope you guys didn't pick A as the answer. Dry cough is the side effect. Second is angioedema. Angioedema, although it is a rare side effect, but it's more dangerous, right? It manifests as swelling of lips or many parts of the body, tongue may get swollen. All this comes under what? Angioedema. So technically the correct answer for this is going to be angioedema, doctors. Okay? So let me just mark it once again. This is our angioedema. Clear? So ACE inhibitors was the answer for this. How do I know this is ACE inhibitor? As you can see in the graph, ACE, if you have blocked, the things before the block will obviously increase and after the block they will decrease. And bradykinin is increased by ACE inhibitor. So technically, if a patient comes to us in clinical practice complaining of dry cough, one of the differential diagnosis always is the medicines called as ACE inhibitor. And if this is there, confirmed as a cause, that means we should shift to sartans. Sartans do not cause this side effects. Okay? So that's that. Now, in this, what I'm going to do is, let us just discuss a couple of things. First of all, essential hypertension. Essential hypertension is that hypertension when I don't know the cause of hypertension. How do you treat this? Essential hypertension has to be treated by three medications. One is A, that is ACE inhibitors or ARBs. Next, C for CCBs. CCBs are those drugs called as dipines, calcium channel blockers. And D stands for diuretics. Okay, D stands for diuretics. So ACE inhibitors, ARBs, calcium channel blockers, and diuretics. These are the things that you need to remember for essential hypertension. Now further, how should we divide this? Assume the person is a young patient who is less than 55 years of age. We should use the drugs called as ACEs or ARBs because in that age, young age, renin is more. Renin is more, so we need to use those drugs that block the RAS system. Example, ACEs or ARBs. Next, if you see CCBs or diuretics, the other drugs, these two drugs should be used in age after 55 years. Okay? CCBs and diuretics, they are used in patients who are beyond 55 years of age. Okay? Now, that is that. Next one, resistant hypertension. Okay? Resistant hypertension. Resistant hypertension is that hypertension in which already the person is resistant to 3 drugs. The person is resistant to already 3 drugs. 3 drugs are not working. One of which is already a diuretic also. So we need to add a 4th medication, and the 4th medication, which is known as the drug of choice, is spironolactone. Okay, so this drug would be known as spironolactone. So that is the drug of choice for resistant hypertension. Now coming to hypertensive emergency. In hypertensive emergency, there are many drugs which are used, but very important, you need to know the drug of choice is nicardipine. Nicardipine is considered as the drug of choice, although many drugs are used. One more you need to know important is nitroprusside. Okay, nitroprusside. Sodium nitroprusside is also used as such an emergency, very important drug. Now, if you talk pregnancy, pregnancy mein the drug of choice is labetalol. Never ever change your answer. This drug is the drug of choice in pregnancy. And second one we can use is a medicine by the name of hydralazine. Hydralazine also is an alternative medication used for treating hypertensive emergency in pregnant women. Okay, so that's that. Now we have to understand from here onwards, basically, if you have some other disease apart from hypertension, try using a drug which can work not only in hypertension, but it works for other disease also. For example, in diabetes and CKD patients, we want to use those drugs which are nephroprotective. Nephroprotective drugs, you need to know, very important, are ACEs and ARBs. Prils and sartans, they are the nephroprotective drugs. That means if a patient comes to us with hypertension and diabetes, the best drugs are ACEs and ARBs. Okay. Heart failure, we just learned heart failure a while ago. And I told you in heart failure, once again, which are the drugs we can use? I can use beta blockers and I can use the same drugs here also. Okay, same drugs I can use, ACEs and ARBs. If a patient is having hypertension with BPH, benign prostatic hyperplasia, we need to use alpha-1 blockers called as Zosyn. Example, prazosin drug we have to use. Okay, prazosin we have to use. Next, Raynaud's disease. Raynaud's disease was a last year MCQ. You have to remember calcium channel blockers are used here. Calcium channel blockers. And finally speaking, for patients who have angina, hyperthyroidism, migraine, anxiety along with hypertension, then we must use the drugs called as beta blockers. Guys, hypertension is a super important topic. Almost every exam has questions, and this is one chart from where questions are anticipated. Please make sure you learn this chart. Okay? So over here we have done a very important chart as such. Now let me almost finish the most important things from this chapter. Let's see here, doctors. What are some side effects of antihypertensive medications? For example, if they say drug-induced SLE, the answer to this is hydralazine. Hydralazine is a drug that can cause drug-induced SLE. And I'm sure most of you already know which drugs cause drug-induced SLE. They are the drugs called as shipped drugs. Okay, this is the mnemonic that I'm sure everybody has learnt already. Drug-induced SLE meaning the malar rash, butterfly shaped rash. If you get after starting drugs, it might be one of the 5 drugs, that is shipped drugs. Okay, and H in the shipped is hydralazine. Okay, hypertrichosis. Hypertrichosis, this is the side effect of a drug called as minoxidil. And because it's causing hypertrichosis, it's a side effect of the drug. Now we use this drug in the treatment of alopecia. We use this drug, minoxidil, as we all know, in the treatment of what? Alopecia. That is minoxidil drug. Okay. Cyanide toxicity. They can ask you which of the following antihypertensive medications have cyanide in its structure itself. The answer to that is nitroprusside. Nitroprusside is the one that causes cyanide toxicity. We just learned dry cough and angioedema. These are due to increase in bradykinin. And these drugs are ACE inhibitors called as prils. Okay, these are prill drugs. Last and the final, headache, ankle edema, gum swelling, etc. is by very common drugs we use called as dipines, calcium channel blockers called as dipines. They can cause headache, ankle edema and gum swelling as such. Okay? So ye charts, the tables I'm giving you, of course this PDF would be shared, right? Annotated PDF would be shared. So don't worry, please just go through this once. All right? Chaliye sir. So now your job starts. My job is almost done. The question begins. A 37-year-old obese male consumes meat, seafood, beer on a regular basis. He has been recently diagnosed with hypertension, for which the patient is currently prescribed thiazides. He presented to the clinic with complaint of red swollen big toe. Red swollen big toe. Fluid aspirate contents of the joint under polarized red light shows yellow needle shaped crystals which are negatively birefringent. Which of the drugs work on the microtubules? All right. As expected, most of you are just in hurry to answer. Don't pick things what you just think you know. All right, read the question properly. Look what the question asks. The last line is the key. They have asked which of the following drugs work on microtubules. So let's discuss these drugs. Okay. Now, first of all of you look here. You have gotten the diagnosis correct. I know everybody knows this is gout. Okay. What are the hints they have given that this is gout, doctors? Red swollen big toe. Thiazides themselves can cause hyperuricemia. That means thiazides itself increase uric acid also. This person eats a lot of meat. Red meat contains a lot of, purines which has uric acid. So technically all those things are there. Then in other subjects you must have learned these words like yellow needle shaped crystals, etc. See, I have given you the cases so that you can get to revise the other parts of our, clinical sciences as well. So that's how the question is. Correct answer to this is colchicine. Now let me explain why. Okay? Because the question has asked you which one works on microtubule. They didn't ask drug of choice. I know each one of you are ready that drug of choice is allopurinol. Okay, you know that. We are here to learn few other things apart from what you don't know, right? So colchicine. Colchicine is the correct answer to this. So sabse pehle, all of you pay attention. The disease called as gout, right, is further classified into two things. One is acute gout and the second is chronic gout. Okay? Acute and chronic gout. In acute gout, the main aim of the treatment is to decrease inflammation. And in the chronic gout, the main aim is to decrease uric acid. Guys, allopurinol, etc., they are drugs to decrease uric acid. They don't decrease inflammation. Right? So my question was inflammation related. Now you need to know one thing. What drugs can decrease inflammation in general? The drugs called as NSAIDs or steroids. Yes or no? Non-steroidal anti-inflammatory drugs. That means they can decrease inflammation. Which is the best NSAID I can use in this scenario? Indomethacin. Indomethacin is the best NSAID I can use here. Okay, so I hope this is clear. Now connect these pieces to your pathology. Guys, you must have learnt in your pathology that neutrophils are those cells which produce acute inflammation. Neutrophils produce acute inflammation. So if I allow neutrophils to go to the site of inflammation, injury, they produce inflammation. So basically, these neutrophils need something called as microtubules, right? Just like a car need tires to go somewhere, neutrophils need something called as microtubules to go to the sites. So now what is our drug colchicine doing? Colchicine is stopping neutrophils from going to the site of inflammation. That's how colchicine decreases inflammation. Please know the point, right? The question asks microtubules पे कौन सी drug काम करती है? That means the correct answer is colchicine. Although colchicine decreases inflammation, it's not used everywhere. The main place where we use it is gout. Okay, hope this is clear. Now I'll answer each and everything. Don't you worry. That's why we are here. Just as a reference to all of you, Dr. Saab, right? Gout mein kya hota hai? As you know, there is arthritis because of deposition of uric acid crystals. And what is the shape of uric acid crystals? As you're seeing here, they are basically, needle shaped as such. चलो एक और चीज भी याद कर लेते हैं. There is something else that I want you to know. There is something which we also call as pseudo gout. Okay, there is one more disease called as pseudo gout that you should remember. Now, pseudo gout, it's a different scenario, and how to differentiate, you just remember this. Positively, positively birefringent crystals. Okay, positively birefringent crystals. And these are not made up of uric acid, etc. Rather, they are made up of calcium pyrophosphate. Okay, calcium pyrophosphate. तो ये याद रख लेते हैं अपन. Gout में you had uric acid crystals which were needle shaped. Here they are positively birefringent in pseudo gout, and they are not made up of uric acid. They are made up of something called as calcium pyrophosphate. Although they have a rhomboid shape, they are different. ठीक है, तो चलो, things in and around we will remember. Is that understood? Now coming to the drugs of gout. Right, here we go with the mnemonic gout itself. What are the drugs I can use? See, first of all, the mnemonic gout itself I had made to make you remember the drugs. In this, I told you steroids and NSAIDs. Steroids and NSAIDs, they are used in the treatment of acute gout. Now, what are the drugs that we use in the, chronic gout? As such, the other ones. These are used in chronic gout. And one more drug in this list which is used in acute gout is colchicine. Colchicine is also used in acute gout only. Okay. Now, once you are clear, let me address one more issue in this topic. Okay. So, to remember some things, let's first figure gout hota kaise? How does gout happens? We have substances called as purines in our body, and these purines will break down into a substance called as uric acid. And this happens by one enzyme called as xanthine oxidase. Okay? Xanthine oxidase is that enzyme that makes uric acid. Once this uric acid is made, now the next thing is this uric acid is excreted by our kidneys. This uric acid would be excreted by our kidneys. If you got this much idea, now let's pay attention here. Right? Two ways I can control chronic gout. Right? Either I can stimulate excretion of uric acid. This is one thing I can do, increase the excretion of uric acid. Or I can block the synthesis of uric acid. Now, there are two ways. If the drug is increasing excretion of uric acid, those drugs are called as uricosuric. And best example is which one? Probenecid. Probenecid is the drug that increases excretion of uric acid. Now guys, listen to me very carefully. Gout is a very, very high yield topic in our exam, and usually question comes on this from pharma aspect. Don't be in a hurry to always choose allopurinol, right? Like for instance, last exam, they have asked which is the drug to increase excretion. And again, people not being attentive have chosen allopurinol as the answer. Allopurinol is a xanthine oxidase inhibitor. It decreases production of, uric acid. Look at the name itself, purine. Purine ko काम नहीं करने देती. Basically, this is a drug that does not allow purines to get converted to uric acid. Febuxostat, xanthine oxidase in the name itself, XO. So allopurinol and febuxostat are these drugs. Please remember, this is the drug of choice, allopurinol, which you all must be knowing already. Febuxostat is also a very great drug. Uricosurics promote excretion of uric acid, right? That is that drug. And finally, a drug that can break uric acid, it is rasburicase. The drug that can break uric acid is called as rasburicase. So now you have this equation right in front of you. Hopefully next time we won't make any mistake. All these points are clear cut in front of you. Okay? Done. Let's solve next MCQ. A woman presented to the OPD with complaints of severe throbbing headache, which is accompanied by nausea and sensitivity to light and sound. Before the onset of above symptoms, the woman sees bright flashes of light, numbness, pins and needle sensation also happens. Which of the following drugs can cause gangrene in the fingers? All right. So most of you have answered and you have answered correctly. Congratulations. That means now you're reading the question properly. They asked you the question, which one causes gangrene in finger? So don't be too excited just to choose the drug you know, as I said, right? So here we go. First of all, this dude is nothing but migraine. They have very clearly described this. Headache, they have described. Next, they have also described the aura. Aura is something that you get to see before even you get migraine. That means you get to know that, yes, I'm going to get an attack of migraine. That's called as aura. Light, flashes of light, numbness, etc. These are all aura things. Ab, sir, the correct answer to this is ergotamine. Okay. Ergotamine is the correct answer to this. Now, once again, let's tackle this. Let's see what are the things that we need to know. Okay. First things first. As usual, the migraine treatment, you all should know 2 points. Migraine में the acute treatment, what do you need to do? First of all, divide the acute treatment into 2 types. If the person is describing mild to moderate type of headache, that is migraine, we use simple drugs, don't use strong drugs initially itself. NSAIDs. NSAIDs have to be given in this. Okay. If the person is having severe type of migraine, now we give the drug of choice called as triptans. Sumatriptan. Like, you can see many of you have chosen that also. Sumatriptan is the drug of choice for migraine. Definitely, I agree that, right? So this is the drug. What is the mechanism of sumatriptan? It stimulates a serotonin receptor called as 5-HT1B. B for blood vessel. B for blood vessel. What does it do on blood vessel? Vasoconstriction. Please remember one thing now. If you want to treat migraine, you have to produce vasoconstriction in the brain. I repeat, if you want to treat migraine, you have to produce vasoconstriction in the cranial vessels, because migraine happens due to vasodilation. So we need to produce vasoconstriction right now. Triptans are those drugs. And prophylaxis, you have to remember, the drug of choice is propranolol. Beta blockers, right? Propranolol is the drug of choice. ठीक है, तो पहले याद कर लेते हैं. Prophylaxis, propranolol है. The word goes together. Treatment में triptans. Treatment, triptans. Are you getting my point here? Prophylaxis is this, treatment is this. Now, the question did not ask us the drug of choice, this, that. They have asked us what? Side effects. That's what we need to discuss now. Okay, I'm going to discuss them shortly. As you can see, different types of headaches, and I can assure everybody agrees on this. All right, so let's go ahead. Here we go. 5-HT1B agonist called as triptans are the drug of choice in migraine, as I told you. Now, what do you need to know? They are basically producing vasoconstriction in cranial vessels, but they will not just do that over there. They may do it in other parts of the body. Triptans, they cause the vasoconstriction in the heart vessels also. That's why they're contraindicated in diseases called as ischemic heart diseases. Ischemia means what? Already the blood flow is less in the heart. The blood flow is already less. That's called ischemic heart disease. Example, myocardial infarction, right? There might be less blood flow, angina, MI. These are the diseases in which there is less blood flow. So let's remember MI just to, you know, keep things easy. I'm just telling you, let's remember MI. So now MI risk, if you're having MI, don't use triptans. You can't use triptans. You have to use some other drug. For that only there is next drug. See here, lasmiditan. Lasmiditan has less risk of MI. ठीक है, ऐसे याद रख लेंगे. Lasmiditan has less risk of MI. So this is our drug, lasmiditan. So that is a safer drug in these patients. Next, ergot derivatives. What do you need to know? Ergot is a fungus that produces vasoconstriction, but this guy produces vasoconstriction even in the fingers. That leads to gangrene. And you know, when gangrene happens, it leads to rotting. You know, it rots our fingers. And there's our mnemonic, ergots rots fingers. Okay, that's how we're going to remember this. Ergots rots fingers. So that's our mnemonic to remember this. That's what the question asked. Chronic mein, as I told you, we are going to use the drugs like propranolol. And remember it like this. People basically who are getting a very severe attack of migraine, they want to stay in bed, right? To prevent more worsening of headache, they want to stay in bed. So mnemonic is chronic migraine is treated by staying on bed. Think of it like that. Beta blockers, E for some drugs we use in epilepsy, some drugs we use in depression. They can also be used as such in migraine treatment. Okay, so that's it. This is what you needed to know with migraine. Next, I would want you to go ahead, read this MCQ. All right, so looks like most of you are getting it correct. Very good job, guys. Now let me once again write down few points that you needed to know to diagnose this problem. Then we will discuss the drugs also, right? Now, the question is clear cut stating that this is a case of DVT. How do I know that this may be DVT? Right, she underwent a surgery, this, that, and they have said that there was a pain in calf muscle, etc. So, technically, D dimers are high. So, all this are indicating that this person might be having DVT. Now, you should know if this person has come to the hospital, we have to give some injectable drugs, and that injectable drug is nothing but heparins. Okay, so low molecular weight heparins would be the drug of choice in the DVT patients. Are you understanding that? Low molecular weight heparin would be the drug of choice for this condition, that is our DVT. Next, the person who is at risk of DVT, they may have to take some prophylaxis medications. Those are some other medications. The prophylaxis of DVT, if you have to do prophylaxis of DVT, there are some other medications we use these days. Okay, so as you saw here, basically for the treatment, we are using the heparins H for hospital. Because they are injectables, we are going to use them as such in hospitals. And oral drugs are usually preferred in the preventions of diseases, chronic treatments. So we use drugs like DOACs and warfarin. DOACs and warfarin. As such, these days you have to remember one important point, that DOACs are mostly the drugs that we prefer to use over warfarin, because warfarin is a drug where you have to do some constant monitoring by a test called as PT. Okay, the test we have to do with warfarin every time is called as PT or INR. That is the problem with warfarin. So usually speaking, DOACs are newer drugs and they are preferred more these days over warfarin. Now, warfarin has one main indication you need to know clinically, and that is, let's remember W. W looks like M. W looks like M. So basically, those patients who have mechanical valves in their heart, if a person has underwent some procedure where we have put mechanical valves in their heart, those people, warfarin is a better drug. Otherwise, the better drugs we prefer are DOACs. DOACs are drugs like Exaban, Rivaroxaban, Edoxaban, these drugs, or Dabigatran. These are the things you need to remember as such. Okay? Now, one or two points I will just say and move on. Okay? See, please do remember there are two drugs. One is antiplatelet drugs. And in the antiplatelet drugs, the top two examples would be aspirin and clopidogrel. Okay, aspirin and clopidogrel or other grel drugs. You have to remember that these drugs called antiplatelets are better in the treatment of arterial thrombi. Okay, they're better in the treatment of arterial thrombi. Example we will take coronary artery disease. Coronary artery disease. Look at the word artery. And what is coronary artery disease? Example is MI, myocardial infarction. I'm sure in MI you all have learned mnemonics like Mona and Sonam. Mona and Sonam, two different types of MI and two different types of treatments. But anyway, what is common in both of them is the letter A. And what is letter A? Aspirin. Aspirin is a drug that has to be given to this patient's lifelong as such, myocardial infarction patients. So antiplatelet drugs are better for the treatment of arterial thrombi, coronary artery problem like myocardial infarction. Okay, so that is that. Next, anticoagulant drugs are what I told you just now, things like DOACs, warfarin, heparins, but the heparins we use these days are called as low molecular weight heparins. They are preferred more over the traditional heparin called as unfractioned heparin. Okay? The hospitals may we use heparin more often, right? And for the maintenance we use oral drugs like DOACs and the warfarin. Okay? These drugs are better in the treatment of venous thrombi. And look at the word we said. Example is DVT. DVT full form as such is deep venous thrombosis. Yes or no? Venous thrombosis, we have to use anticoagulant drugs. So that is the idea that you needed to know as such. Okay? Let's move on to our next topic. Here's our next question. Patient was started on a medication for a neurological condition, following which the patient presented with symptoms shown below. Which of the following drugs may have caused it? Read properly. Okay, so I hope you guys are done with this. First of all, let's all try and understand couple of things here. And one of the first things we should get here is this condition is torticollis, as you can see. Okay, so this condition is nothing but torticollis, as you saw here. Now, knowing torticollis is not enough, right? This comes under something what we call as acute muscular dystonia. Okay, so this thing comes under what we call as acute muscular dystonia. So this acute muscular dystonia is something that happens in patients after starting medications called as antipsychotic medications. After you start antipsychotic medication, there is a risk of this side effect, and it happens usually 1 week. Within 1 week of starting this, we are going to get this problem. Okay, I hope this is clear enough first of all. Now, can all antipsychotic drugs do this? Theoretically, yes, but it's seen mainly with high potency drugs. Okay, this is seen mainly with high potency drugs as such. This is the word that we need to put in our mind first of all. High potency drugs can actually do this. Now, who's the example of a high potency drug who can do this? H for H, it is haloperidol. Haloperidol is the cause of this problem. The question asked, who causes this problem? So our clear-cut answer is nothing but haloperidol. Now, haloperidol is a first generation antipsychotic, right? And we have one more second generation also that you need to know, risperidone. So there are two drugs, high potency. You have to make sure you remember. One is haloperidol and second is risperidone. Okay? Now, if you got this much, what do you need to do? Are we just going to stay like that when the patient is having so much difficulty? No, we will treat this problem. We will not stop giving haloperidol. Haloperidol is a mainstay of treatment of psychosis. Psychosis is a dangerous disease. I can't stop it as such. So what am I going to do? I will continue haloperidol. This side effect needs to be treated. And the treatment of side effect is also given in the same options. It's drugs like benztropine, benzhexol. So let's discuss all these things right here. Sabse pehle, I want you to understand what is happening here. See, usually in our basal ganglia in the brain, there is a fine balance of two things called as dopamine and acetylcholine. Dopamine and acetylcholine. So now in psychosis treatment, you must be already knowing we block dopamine. If you block dopamine, who is looking high right now? Acetylcholine. Acetylcholine is looking high. So if you want to treat this, I can't stop, blocking dopamine. So what will I do? I will decrease acetylcholine. I'm going to decrease the acetylcholine. So muscarinic blockers or acetylcholine blocker drugs are as such given in this scenario. Okay? So let's go ahead. See here. When you give psychosis treatment, there are group of side effects that will come, and these group of side effects are called as what? EPS, extra pyramidal side effects. And you can remember the mnemonic adapt now. So EPS, what are adapt now? First one, acute dystonia, as we discussed already. This happens within 1 week of starting haloperidol like drugs. This is treated by drugs called as benztropine, benzhexol. Okay, benzhexol, benztropine like drugs. Is that understood? Now, next thing, you can see Parkinson also, meaning treatment of psychosis. Psychosis drugs will cause Parkinson. This is called as drug-induced Parkinson. And again, we treated by the same drug, benztropine, benzhexol. And we have one mnemonic we use in class, par cure benz. Yes, to treat drug-induced Parkinson's, we use which drugs? Benz drugs. Par cure benz. Akathisia, one more issue. Akathisia is treated by drugs like beta blockers, right? I'm not going to discuss what all happens as symptoms. Just know this is treated by beta blockers. Tardive dyskinesia. tardive dyskinesia. This is treated by a drug called as valbenazine. Okay, this is the drug we can use, valbenazine. And neuroleptic malignant syndrome, right? The drug of choice is dantrolene. Okay, so these are the treatments that you need to know. So basically, please get this idea. For the last time, I'm telling you what is happening here. When you're treating psychosis, you're blocking dopamine. And if you're blocking dopamine, it may be blocked too much and it induces Parkinson-like effects called as drug-induced Parkinson. But it's not the only side effect. There are many side effects you can see here called as extrapyramidal side effects. Does that mean we will stop haloperidol because of this side effect? No. We will continue haloperidol or some other drug, whatever is causing this, and we will just treat those side effects. So this is something very important from antipsychotics topic you needed to know, doctors. Okay? So that's done. So our next question, a patient complains of muscle weakness that becomes progressively worse during periods of physical activity and improves after periods of rest. Typically, the weakness and fatigue are worse towards the end of the day. Physical examination was performed and there was no hyperemia or pharyngeal exudate found, but ptosis, diplopia, dysphagia was noted. On CT evaluation, thymoma was found in this patient. What drugs can be given for the initial diagnosis of the patient? All right. So I believe this doesn't need much of a time. You guys are already ready with your answers. What is this all famous disease that you got to know for your examination? This is myasthenia gravis. Myasthenia gravis. How does myasthenia gravis presents? It presents with muscle relaxation. Muscles are relaxed in this, right? That's why there is muscle weakness, what they're saying. So how did the patient come? The patient came as such, with certain symptoms of weakness, etc. Okay. Now look at this. One more hint was given, thymoma. Please make sure you remember this. It may not be our subject, but it's important for exam. Myasthenia has a relation with something called as thymoma. Now they are asking you what is the drug for diagnosis. As all of you have answered, too easy for you all, edrophonium. Okay, so let's see here. Guys, first of all, because the patient is having muscle relaxation, you know what happens? Their eyelid will be drooping now. As you can see in this patient right now, the eyelid is drooping. This is called as ptosis. The patient comes with ptosis. Now what we do is we give our drug called as edrophonium, and when you give your drug called as edrophonium, so the idea is this: the edrophonium drug starts contracting muscles and now the eyelid will open. That means the patient is feeling better after giving edrophonium. Is that understood, doctors? So this is the test we do as such in the initial diagnosis. Okay, and the name of this test is tensilon test. Tensilon test is the name of this test, where the eyelid has opened. Once the eyelid has opened, now what do you need to do is give the treatment. Long acting drugs have to be given. Edrophonium is a short acting drug. We prefer in diagnosis. Now we have to use the long acting drugs in the treatment. Example, pyridostigmine or neostigmine. Better would be pyrido as it's more longer acting, along with atropine. Atropine also needs to be given in the management. Since it is an autoimmune disease, antibodies are present, I have to give immunosuppressive drugs if needed. And what are the immunosuppressive drugs? Steroids or some other drugs like azathioprine, etc. These are all immunosuppressive drugs. And last and the final, myasthenic crisis, right? Myasthenic crisis is something else what you need to know. First, understand, if let's say the patient is having less acetylcholine and you give them more acetylcholine, the patient will feel better. The patient will feel better. But if the person is having already too much acetylcholine and now further you give acetylcholine, patient will not feel better, rather the patient may get worse. And that place where patient is already having too much acetylcholine in their body, that's called as myasthenic crisis. Why do you think myasthenic crisis can happen? Patient may have taken too much dose of this drug, right? Patient may have taken too much dose of this drug. So that's where myasthenic crisis happens, and we have to treat it by something called as plasmapheresis or IV immunoglobulins. Okay, so those are more of medicine questions. I'm just trying to give you an insight on over here. But 90%, this question on myasthenia comes on pharma, and very easy, as you have all answered. Edrophonium is used for diagnosis. Treatment is this. This is where mostly the questions come from. Okay? So that's all that you needed to know. This is your, myasthenia gravis. All right. So I hope you guys have done a good diagnosis over here, what this question was asking, etc. See, all these points that are mentioned here are straight away hinting us towards what? Glaucoma. Nothing if we figured still from these lines, I hope we all could have figured that this is glaucoma. Normally, intraocular pressure should be how much, doctors? Normal intraocular pressure should be less than 21 mm, less than 21 mm of mercury. Okay, that's a normal intraocular pressure. Here it's very, very high, as you can notice. See, question is not asking you the treatment of something. Very subtle way the question has been given. If you're paying attention, this question will be easy. They have already given asthma, right? Basically, I have, right? So I have given asthma in this question here. That means you have to know it's not just some random treatment of this glaucoma they were asking. They were asking which drug to be avoided in a patient of glaucoma having asthma. And the correct answer to this would be timolol. Okay, timolol is nothing but our beta blockers. Timolol is our beta blockers. So this is what first of all we all should know. Chalo aate hain. We will come to these points one by one. First, let's see here what are the things to be known with anti-glaucoma drugs. Okay, first things first. In glaucoma, we need to decrease, intraocular pressure. We can decrease this either by increasing the drainage of aqueous humor, or we can do it by decreasing the aqueous humor production itself. Okay? So either we can increase the drainage, or what is the other thing, doctors? We can decrease the synthesis or production. Now, what are the drugs that can increase the aqueous humor drainage? Okay, what drugs can actually work on this drainage? This is what we will start with. First of all, let's see one by one, starting from here. As you may be seeing here, aqueous humor drainage can be increased by two different pathways, one called as trabecular meshwork and the second is uveoscleral outflow. Trabecular meshwork and uveoscleral outflow. So let me write down uveoscleral outflow. The drugs that increase the drainage from here, they are drugs that stimulate something called as PGF2 alpha. These are the drugs that stimulate PGF2 alpha. Now, these drugs are the drug of choice for open angle glaucoma. Please remember, these drugs become the drug of choice for open angle glaucoma. Next, trabecular meshwork. We have drugs that come under this called as meiotics. Okay, the drugs that produce meiosis, they will increase trabecular drainage, and these may be drugs like pilocarpine, physostigmine. These drugs are meiotics which can be used, but one of them is very important, that is pilocarpine. Pilocarpine, it is the drug of choice for closed angle glaucoma. Pilocarpine, it is the drug of choice for closed angle glaucoma. So what is one type of drugs that can increase trabecular meshwork drainage? Meiotics. Second drugs that can work here, they are alpha 2 agonist also. Alpha 2 agonist drugs, they also can actually increase the trabecular meshwork drainage. Okay, so these are drugs, some from this other areas. Now if you just memorize these guys working on the drainage pathways, we can remember the other drugs. That means most of the drugs of glaucoma, let me just write that statement, most drugs of glaucoma, they do what? They decrease production of aqueous humor. And how exactly are we going to remember them? By the mnemonic A, B, C, D. Okay, 4 drugs which can decrease the aqueous humor synthesis or production. Now first one who comes under this, these are the drugs called as alpha 2 agonist. Alpha 2 agonist. So now as you can see, alpha 2 has 2 mechanisms. It decreases production also, and it decreases increases the drainage also. 2 mechanisms are there. Next, B for obviously beta blockers. Beta blockers, example timolol, bitoxolol, levobunolol. These are the beta blockers that we use here. Next, third one in the list is carbonic anhydrase inhibitors. Guys, we have already finished now diuretics called as carbonic anhydrase inhibitors. So make sure you know this. These are drugs like acetazolamide, dorzolamide, etc. Next and the last one is drugs called as dipivefrin, which is nothing but epinephrine or adrenaline. Dipivefrin is nothing but adrenaline as such. So ye words, if you are clear enough, now what are we supposed to know as such? First, we have divided mechanisms. We have learned that drugs, they will decrease production of aqueous humor. Many drugs do that, A, B, C, D. Most drugs are here. The drugs that work on drainage are others. See, first of all, let's try to create an analogy. I might be wrong, but what is the analogy? You have to start thinking that to decrease the production, it will take time. So removing the aqueous humor will be faster. So those drugs are the drug of choice. The drugs that remove are the drugs that increase the drainage. That means they are faster. So let's remember it like that. 2 drugs. Open angle glaucoma, 1 pathway. Which is that pathway? Uveoscleral pathway. Trabecular meshwork pathway, the drug of choice, one more exists there. That is pilocarpine. The drug of choice for what? Closed angle glaucoma. Okay. Now let us discuss 1 or 2 things as such. When I say the word open angle glaucoma, I have already told you the drug of choice is prostaglandins. The drug of choice is prostaglandins called as PGF2 alpha. I am going to discuss them shortly. Now, hope you guys also remember that the surgeries that we do here are trabeculoplasty, and second one, trabeculotomy. Okay? The surgical interventions that exist for open angle are these ones. Next is basically closed angle glaucoma. Closed angle glaucoma mein, what do you need to know? The main treatment of choice. The treatment of choice, if anybody asks you, you must be knowing this already from your opthal. This is nothing but laser iridotomy. Okay, laser iridotomy, this is what is one of the preferred treatments as such for closed angle. Now, there are one or two things that are needed to be known that I will discuss here. Chalo, kya yaad rakhna hai? What are things to be remembered for closed angle glaucoma? Closed angle glaucoma, initial treatment, it is not pilocarpine, but rather it is IV drugs to be given. It must be either mannitol. Initial treatment in closed angle, it is mannitol, and we give it a word when there is very high pressure. We call it as acute congestive glaucoma. Acute congestive glaucoma. Acute means an emergency, right? Acute congestive glaucoma, we use either IV mannitol or acetazolamide. Acetazolamide. These are the two drugs that you needed to know, mannitol or acetazolamide. Okay? Now, if that is done, later what we do is, once the patient is stabilized little bit, okay, once the patient is stabilized little bit, now you will switch to the drug called as pilocarpine. So this is what you need to know. In the ACG, when the pressure is really high, pilocarpine is not that effective. So technically mannitol or acetazolamide, this is what we need to know. After that, we will switch to pilocarpine. This is closed angle glaucoma. Now, last and the final, in the open angle glaucoma, one or two drugs that are there. What is important? Let's learn. So first of all, these are the drugs, what we call as PGF2 alpha drugs. Okay, PGF2 alpha drugs. Examples are names like latanoprost, okay, bimatoprost, etc. Latanoprost, bimatoprost, these are the medications that come under examples of PGF drugs. तो अपने को क्या याद रखना है? What do we need to remember? These drugs, certain side effects and important things will be asked in exam. That's what we'll memorize here. These drugs cause pigmentation of iris. Pigmentation of iris. Iris is something which give colors to our eyes, yes or no? So it causes pigmentation of iris. And this will be usually notable in those people whose eyes are light color. See, for example, as an Indian, my eyes are already dark. So more darkness cannot be easily figured, right? So this we see in those people in which the eyes are light colored. Sometimes what happens, in one eye, the color becomes more darker than the other. And now the eyes look two different colors. So this is given one name, what we call as heterochromia iris. Heterochromia iris. This is something you need to know. Hetero means different color of iris. Next, second side effect, this guy causes growth of eyelashes. These drugs cause growth of eyelashes as a side effect. And what you need to know right now, bimatoprost can be used actually for growing the eyelashes, right? Third, what do you need to remember with the F word? It is increasing the flow now. Which flow? Uveoscleral outflow. This drug is increasing the uveoscleral outflow. So that is what you needed to know. Very, very important things. And last things, but not something lesser important. These drugs are prostaglandins now. Prostaglandins, they increase inflammation. Prostaglandins, they will increase inflammation. And for that reason, if a person is having some inflammation, we can't use it. Example, they are contraindicated in uveitis. Okay, itis means inflammation. Since these drugs increase inflammation, we should not use them. So that is what we needed to know as such. Okay, so from this glaucoma topic, these are things which are very high yield, and usually once again this is one more topic where questions are expected from. Okay. So next question right in front of you. A patient with an infection was administered IV penicillin, following which the patient develops hives, wheezing, swollen tongue and lips, tingling sensation, confusion, severe hypotension. What is the drug of choice for the management of the current situation? All right. So looks like you guys have already figured the answer. The correct answer to this is epinephrine or adrenaline. So what are they basically describing in this questions? See, antibiotics called penicillins are actually known for something. What are penicillins known for? They're known for causing anaphylaxis. So these drugs, they're known for causing what? Anaphylaxis. And for anaphylaxis, the drug of choice is nothing but adrenaline. Okay? Now, let's just quickly write down what are different drugs in this topic. Anaphylactic shock, the drug of choice is adrenaline. Okay. Next, vasodilatory shock, the better answer is noradrenaline. Cardiogenic shock, any one of dopamine or noradrenaline can be used, but if oliguria is present, then definitely the drug of choice is dopamine. So cardiogenic shock with oliguria, dopamine becomes the drug of choice. Now there is a reason for everything. Dopamine technically works on three receptors called as D1, beta 1 and alpha 1. Right? Dopamine works on three receptors, and the D1 receptor causes diuresis, and this diuresis will help you treat which patient? Oliguria. So you should remember it helps you treat the oliguria patient. So that's why this drug is preferred if you want to work on heart also, kidney also. Which is the only drug which is working on kidney as well? It is dopamine. So dopamine is preferred for this scenario. Now, next thing, anaphylactic shock. Why adrenaline is the drug of choice? In anaphylactic shock, bronchoconstriction is present and we need to produce bronchodilation. Bronchodilation. Apart from increase, see, in all these shocks, we want to increase BP. Shock means I want to increase BP, that is there with everyone. But extra problems can we solve? That is the question. Adrenaline can produce bronchodilation, and for that reason, adrenaline is the drug of choice because adrenaline works on beta 2 as well. Adrenaline works on beta 2 and that beta 2 produces bronchodilation. Hence, anaphylactic shock, the drug of choice is adrenaline. Other guys do not work on beta 2. That's why they are not preferred in anaphylaxis. Now, there are a couple of things I want you to learn with adrenaline, sir. Okay? Adrenaline when we use in anaphylactic shock. Adrenaline when we use in anaphylactic shock, the route that is generally preferred is intramuscular, and the concentration of choice that is preferred is 1:1000. That's what you needed to know. 1:1000 adrenaline, that is preferred one. Okay? And make sure you do revise other concentration, other uses of adrenaline. Okay? Go ahead. This is your next question. Okay, so looks like you guys all got it correct. So what was basically mentioned here is nothing but datura. And I'm sure most of you, just by looking at the picture itself, you guys had figured out that we are talking about datura over here. Yes or no? So good job. How do I know that this is datura? Look at the complaints. What happens in datura toxicity? There is decrease in the parasympathetic functions. There is decrease in the parasympathetic functions. This is what we needed to know as such. Okay, this is my first word I wanted you to know. Chaliye. So if you got this much idea, now let's discuss few things in here. Check it out. So what you need to know is how can you increase parasympathetic back again, right? The way to increase parasympathetic back again, it is nothing but a drug called as physostigmine. Okay, so here in this chart, what I'm going to do straightforward is let's write down some antidotes which are important in pharmacology, sir. Okay, OP poisoning and carbamate poisoning. Okay, these are those problems in which parasympathetic functions are more. There is too much increase in parasympathetic. So this time I want to decrease parasympathetic in the treatment. We give atropine. Atropine will decrease parasympathetic. On contrary, let's say somebody have taken too much atropine or datura or belladonna. You can remember the word bad here. Whenever the situation is bad, when parasympathetic is less, we have to do the opposite. We will increase it by giving physostigmine. Physostigmine, what does it do? It increases parasympathetic. Physostigmine, it increases this thing. Beta blocker toxicity, we have to give something called as glucagon. Okay. Beta blockers decrease something called as cyclic AMP. Glucagon increases cyclic AMP. That's how they are reversals. They are the antidotes. Okay. Next, digoxin, we have to remove it by giving somebody who binds to it, somebody called as digibind. Paracetamol. Paracetamol, basically what it does is it increases a substance called as NAPQI. N-acetylcysteine decreases NAPQI. Okay, that's that. Benzodiazepines. Okay, benzodiazepines, there is an antidote by the name of flumazenil. This is flumazenil. And for alcohol, it is fomepizole. For alcohol toxicity, it is something called as fomepizole. So as such, these are all the antidotes that you need to keep in mind, dear friends. Ab kahani, what you need to know is not every time we may have an antidote for everything. Okay. So for everything, I may not have an antidote. So what am I supposed to do when antidote is not available and the drugs have been, as such ingested by somebody and all these things? So let me just bring you to that very important point. Okay. So let's learn something. When antidote is not available, what can we actually do in the treatment? First, you need to know if the drug is acidic or alkaline in nature. Okay, what do we need to know? First, if the drug is acidic or alkaline in nature. Acids a lot of time contains 8 in their name. Acids contain 8 in their name. 8 is a short form for acid. Example, folic acid in short is called as folate. 8 means a acid. And alkaline drugs, look at the word, the last 3 letters are in. In is the last 3 letters. Now, if you want to treat them in toxicity, okay, their toxicity treatment, acidic drugs, how to remove from the body, alkaline drugs, how to remove from the body. These drugs, they won't like the opposite environment, right? They like the same environment, they don't like the opposite environment. So basically, if you want to remove acidic drugs, we need to do opposite, meaning make the body alkaline. So we do something called as Forced alkaline diuresis. So we are going to do something by the name of forced alkaline diuresis. Make the body alkaline so that the drug is excreted. So this is done by giving sodium bicarbonate or simply bicarbonate. Bicarbonate is a alkali. Bicarbonate is a alkali. Alkaline drugs, we need to do exactly opposite. Since they are alkaline, they don't like acidic environment. We need to do something called as forced acidic diuresis. This is done by something called as ammonium chloride. Okay, this is done by ammonium chloride. We need to make the body more acidic. Think of it like that. Acid को alkali नहीं पसंद है, alkali को acid नहीं पसंद है. It's just opposite. It's just opposite. So if you want to remove them, make the body like that. For example, very important, they can ask in exam. Aspirin is a acidic drug. How do I know? Aspirin comes from salicylic acid, right? It's a derivative of salicylic acid. Barbiturate is clearly shouting at me that it's a acid. So how can you remove acids from the body? Alkaline diuresis. So that was the antidote that you needed to know, doctors. Okay. So that being done, let's move to your next question, sir. All right. Looks like you guys are all ready. First of all, what is the diagnosis of the thing that is given over here? You can very clearly appreciate something called as bird's beak appearance. Yes or no? Bird's beak appearance. This becomes the diagnosis of what disease? Achalasia cardia, right? This is the disease called as achalasia cardia. So now, once you have diagnosed this disease, what you need to know, my dear doctors, is what drug is used here, right? Botox. Botox is the drug that we use in the treatment. Kyun bhai, why Botox? As you can very clearly see, it's the contraction of lower esophageal sphincter. Yes or no? There is a contraction in the lower esophageal sphincter. And how can you treat a contraction? By relaxing it. And what is the drug that will relax muscles? It will be Botox. So Botox relax muscles. So guys, this is what you need to know. And how does Botox work? The answer is it inhibits the release of acetylcholine. Okay, it inhibits the release of acetylcholine. Acetylcholine's job is to contract muscle, but if you block its release, the muscles cannot contract. That means they will relax. So Botox relaxes muscles. That's why we use it whenever we want to treat a contraction. Example, if your eyelid is having too much contraction, what do you call that too much contraction? Blepharospasm. Blepharospasm. How do I know it's a contraction? Spasm. Torticollis, we can use Botox. Cervical dystonia, we call it. Achalasia cardia, I can use Botox. So these are some uses apart from the cosmetic use of Botox. You all know Botox is used for wrinkles, etc., right? So basically those are cosmetic uses. Apart from this, this is what you needed to know. Okay, next one, guys. And by the way, I hope you remember Heller's myotomy. This is the surgery that is performed for achalasia cardia. All right, doctor. So let's go ahead. A patient was started on a medication for the management of asthma, following which the patient presented with the lesion as shown in the image below. Which of the following is least likely to cause this? See, we all know in the disease called asthma, we use steroids by inhalational route. Okay? Steroids, you can think of it that they decrease immunity, hence they are used in asthma because asthma is a hypersensitivity, too much immunity. You want to suppress that immunity by using what drugs? Steroids. Okay. Now, those steroids, since they are taken by inhalational route, we call them as inhalational corticosteroids. Okay. Now, understand very important point. All steroids, because they decrease immunity, they can increase the risk of infections. And this infection, what you can see, is nothing but your oropharyngeal candidiasis, what we can call as oral thrush. Okay, we can call it as what? Oral thrush. This is the thing you needed to know as such. Okay. Next, what else do you need to understand over here, sir? Oral thrush, this we said now. Which steroid does not have a risk of this oral thrush? So how is this happening? Why this colavir D? Right? You have to know, okay, if all steroids are causing this, then how come one is not causing? Understand. The first thing is to know the answer. The answer is cyclosonide. Cyclosonide, why it does not cause this side effect is it's a prodrug. Guys, you may all be knowing what is a prodrug. Prodrug is a inactive drug. It's an inactive drug. That means when you take this drug, it's in an inactive form. Then you will ask me a question, sir, if it's inactive, then why are you taking? See, the idea is this drug, when you take, it's inactive. That means it cannot lower immunity right now. But once it reaches your lungs, now it becomes active. Prodrug is a drug that is inactive when you take it, but inside human body, it will become active. So the point I'm making here is this drug is right now inactive. So even if you put it in your mouth, it's not going to decrease immunity and cause this infection. So when does this drug work? Once it reaches lungs. That's the reason it does not cause this side effect. Okay. So that's all that you needed to know as such. So technically, once we are done with this, now what are some things we can do? We should always ask the patient to gargle their mouth after they have taken this drug, so that you can prevent this oral thrush from happening. Or there are things called as spacers, I told you in classroom, that we can use to prevent this. If it has already happened, oral thrush, if it has happened, you should know who causes oral thrush. It's by somebody called as Candida, who is a fungus. Candida is nothing but a fungus. How do you treat any fungus, sir? Antifungal drug, right? So treatment of this can be antifungal drugs like cotrimazole or nystatin. Okay, so this is what we are going to use here. Cotrimazole or nystatin. These are things as such we use to treat this condition. Okay, so that's all that you needed to know for this question. Chaliye, let's move on to the next one, sir. A 52-year-old patient who is currently on metformin with HbA1c value of 7.2 had a myocardial infarction 3 years ago. Further cardiac evaluation shows ejection fraction of whatever, blood pressure, blah, blah, blah is given. They're asking which is the most appropriate medication to be added in the regimen of this patient. I would definitely say this question is slightly on the difficult side for sure, but that's the whole purpose. We want to learn these things, Doc. Okay, and if you answer this, you guys are rocking this. Okay, as I can see, majority of you are answering linagliptin, and I can already assure you the reason you're answering linagliptin is because it's safe in renal failure. Yes or no? You're answering that because it's safe in renal failure. Dr. Saab, this is not a renal failure case. This is a heart failure case. How do I know that? Please have a look at this. Ejection fraction is 48. That means it's a heart failure case. Okay, good job. You are going to mark that correctly. I know that. Linagliptin. Lina he lena. That's what we said, right? In renal failure, lina he lena. Why? Because all gliptins are removed from kidney except which guy? Linagliptin. Safe in renal failure. Very good job. But this was a case of, you know what? Heart failure. So anyway, it's all right. Let's learn it here, Dr. Saab. The answer to this is option D. Canagliflozin. Canagliflozin. चलो सीखते हैं. Let's learn this. Guys, once again, I'll bring you back to this. Check it out. Imagine this is our kidney and this is our blood vessels. Now, as I told you earlier also, there is a process called as reabsorption that is happening in us. And Dr. Saab, if you know reabsorption, there is a channel here by the name of SGLT2 channel. Okay, SGLT2 channel. What is the function of this channel? S stands for sodium, GL stands for glucose. SGLT2 stands for sodium glucose transporter. That means from the urine, sodium, basically water obviously, and glucose, they are coming back into my blood, right? They're coming back into my blood through this channel. And guys, if you have blocked that exact channel, don't you think you're losing sodium and glucose in the urine? If you're losing glucose in the urine, meaning glucose is decreasing in the body, it becomes treatment of diabetes mellitus. And if you're losing sodium from the body, it helps you in heart failure. It's decreasing workload on the heart, right? It's decreasing workload on the heart. So for that reason, this drug is approved for patients in heart failure. On the other hand, pioglitazone is contraindicated in HF. Why? Because it increases the sodium in the body. It increases the sodium in the body. For that reason, pioglitazone is contraindicated in heart failure patient. And this one is indicated, right? So that's about it. I know that linagliptin men, if I would have asked, all of you would have answered correctly, which you know, you should be happy. Guys, please don't feel anything if you're not able to answer one or two questions here. The point is to learn before the main match. This is our practice ground. Let's make as many mistakes as possible. We will rock the day of exam. Okay, so this is what it is. अब आप खुद देखना कि if I give you SGLT2 blocker, the glucose is flowing in the urine. Yes or no? Sodium is flowing in the urine. So you can just add a word urine next to this drug name and figure out everything. Glucose flows in urine. When you give this drug, what is happening? Glucose flows in urine. That's what's happening. And if more glucose flows in urine, now you will start getting genital infections, UTIs, etc. It's not normal for so much glucose to come into your urine. Now, because of using this drug, so much glucose is excreted. Glucose-urea is happening. And for that reason, you get UTIs and genital infections. So that is that. That is the correct answer. So chaliye sir ji, diabetes, important points. Let's learn here. Which drugs in diabetes causes hypoglycemia? Mnemonic sim hai yahan pe, hypoglycemia. Okay, Kulja sim, sulfonyl ureas, those drugs that end with ide. Sulfonyl ureas end with ide. Meglitinides end with ide. Insulin to insulin hai. Insulin can definitely cause hypoglycemia. But which insulin can cause hypoglycemia? Short-acting insulins. Short-acting insulins. Example, glulicine. Okay, glulicine, aspart, and lispro. These guys can cause that. Okay? And two mnemonics I'll give you, whatever helps you remember. First one is short girl. If you can't remember this, worse come worse, S is always there in the name of short-acting insulin. S is there in the name of short-acting insulin. Short-acting insulin, S for S, sulfonyl urea, they are going to cause what? Hypoglycemia. Next, ये अच्छे से याद रखना है sir. Weight gain is caused by certain drugs. Again, SIM. weight loss is by number 1, number 2. ऐसे याद करेंगे. Which and which guys can cause weight loss? GLP-1 agonist and SGLT2 blockers. And as a matter of fact, one drug from GLP-1 agonist is approved for weight loss, liraglutide. Liraglutide. Okay. Renal failure, which one is safe? Of course, linagliptin, because it's removed from liver, it's safe. And also know the drugs called as glitazones. Glitazones, they are also safe in renal failure. Glitazone कौन है? ये वाली pioglitazone. CHF, contraindicated is glitazone, safe is SGLT2 inhibitors. This was our MCQ. Now, some more added points we need to know. Diabetes patient get 3 complications which everybody must be knowing right now: nephropathy, neuropathy, and retinopathy. Nephropathy, I told you, nephroprotective drugs have to be given, called as ACEs or ARBs. We learned before only. Neuropathic pain is treated by something called as pregabalin, GABA. GABA decreases pain. Next, retinopathy, we have to give those drugs that block VEGF. What is VEGF? Vascular endothelial growth factor. If more new blood vessels are formed in the eye, what happens? New blood vessels are very weak. They may start bleeding. They may start bleeding. Are you understanding what I'm saying? New blood vessels are very weak. They may start bleeding. So that's why we don't want new blood vessels to form. So we use something called as vascular endothelial growth factor blockers. Bevacizumab and ranibizumab. दो drugs होते हैं, bevacizumab and ranibizumab. So that's that. बेवकूफ रानी याद रखना. Please remember, बेवकूफ रानी आंखों में चुभती है, ठीक है, बट क्या करें, प्यार है उससे. So you have to remember retinopathy, bevacizumab and ranibizumab, right? So this queen, basically Rani means queen, as we know. So this one is in your eyes. Just remember it's for retinopathy. Okay. Gastroparesis is treated by a drug called erythromycin. Diarrhea के लिए याद रखना, it's not infectious diarrhea, it's neuropathic diarrhea. Clonidine is used as such. तो ये था आपका डायरिया की कहानी. Okay. Now we are coming pretty much to the end, like there are 1 or 2 more chapter questions that we are discussing here. Chalo, this one I'm hoping you guys answer much quickly. Okay, so straightforward. Although there was all the twisting around in the question, you guys picked up the point, right? The woman is pregnant. I don't care anything more. I don't have to read the question. Woman is pregnant, first trimester. The drug of choice is propylthiouracil. PTU is the drug of choice in first trimester, right? In the first trimester. And how about methimazole, carbimazole? These are the drugs that are used in the second and third trimester. ठीक है, second and third trimester. Radioactive iodines absolutely contraindicated in pregnancy. Radioactive iodines are contraindicated in pregnancy. ठीक है, so that's what that you needed to know as such. चलिए, next, coming to some things that we needed to know as such. Hypertension topic में which drugs are contraindicated? The drugs that are contraindicated are ACEs and ARBs because they cause renal agenesis, and the safe ones are obviously drugs like labetalol, okay, hydralazine, what we already learned, and methyl dopa. Okay, one more drug by the name of alpha methyl dopa. So these are safe drugs in pregnancy. Hyperthyroidism में the safer drug we all know is PTU. Methimazole, carbimazole, why are they avoided in first trimester? They cause things called as cutis aplasia and esophageal atresia, choanal or esophageal atresia. Epilepsy में valproate is the most teratogenic drug, and we remember it like this, it is very teratogenic drug. Very teratogenic drug is valproate, most teratogenic in fact. Next, who are the least teratogenic drug, who are the safe drugs? So we will remember least teratogenic drugs. They are from L. The safe answer here will be levetiracetam. Levetiracetam is the drug of choice. Levetiracetam is the drug of choice, and another drug is lamotrigine. Lamotrigine, two anti-epileptic drugs right here which are safe in pregnancy, levetiracetam and lamotrigine. Next, bipolar disorder. Bipolar disorder में we use a drug called as lithium, but in pregnancy we can't use it because of Epstein's anomaly. So which drugs are used in pregnancy then? Antipsychotics are used. Antipsychotics are used, doctors. Anticoagulants, warfarin should be avoided. And what do you use is heparins, especially low molecular weight heparins should be used in pregnancy. Vomiting. Vomiting may the drug that is contraindicated, which was once used, I don't know, that was a mistake. It causes something called phocomelia. I will show the picture right now. This is phocomelia patient as such. So if the mother has taken that drug for morning sickness, right, the baby gets this thing called as phocomelia. So that's why we have to avoid that drug called as thalidomide. Next, doctors, what you need to know, what is the safe drug? Doxylamine. Doxylamine is the drug of choice for morning sickness. It's an antihistaminic. Last, antibiotics, most of them should be avoided except 3 antibiotics we can use. They are PCM. Okay. Penicillins can be used. Cephalosporins and macrolides. Okay, penicillin, cephalosporin and macrolides, these are safe one that we need to know as such. Okay, so this is what is the story as such. Next, चलिए ये पहचानिए आप लोग. This is something important that you guys need to know. From this graph, you have to figure out which drug has highest potency and highest efficacy from this. Okay, highest potency and efficacy. These are the two things that you need to know. All right. So let me just take you into this story now. So first things first, dear doctors. In this graph, as you can see, two things are mentioned. Okay. One thing that is mentioned here is potency, and second, they're asking something called as efficacy. Two different things now. Two things were asked in one question. So how to answer this? Let's see. First part is this, sir. Who's the most efficacy drug in this? Option B. And who's the most potent drug? It is option A. Okay. So since the question asked potency first and efficacy next, so this is the correct answer. Okay. A and B. A and B. The question have asked highest potency drug कौन सी है? Highest potency drug is drug A. Highest efficacy drug is which one? Option B. ठीक है. let me just address all those things now. All those things, let us try to see. In this graph, first, as you can see on this axis, response is measured. Response is nothing but efficacy of a drug, efficacy of a drug. And there is one more word to talk about efficacy, which is Vmax also. Vmax also. Now the next thing is dose. Dose is nothing but Km, and Km is related to potency of a drug, and they are actually inversely proportional. Inversely proportional. What do I mean by this? Okay. Just to keep things simple, to explain you, I will write here. Assume this is left side and this is right side. Left side and right side. And this is the dose like 5 mg, 10 mg, 20 mg, 50 mg, 100 mg, 500 mg, and so on. So technically, when I ask you the dose of something, potency, you should not look how much effect it's producing and all. You should just see the bottom area. Which drug requires the least dose? The answer is this one. 5 mg, it's producing effect. That means it's the high potency drug. The drug that requires less dose is called high potency. Okay. So this is what we need to know. Now, next part is right side. If you move, they are requiring more dose. That means they are low potency drugs. So from this graph, this is a low potency drug and this is high potency drug. So can I say from left to right, the potency is decreasing? Agree? From left to right, if you move, the potency of the drug is decreasing. That means they are requiring more and more dose. When I ask you dose, look only at dose. Do not look at effect. I don't care how much effect they are producing. Okay, so that's done. So from this, first of all, the question asks which is the highest potency drug? Option A. That's why that is that. Next, efficacy. Efficacy is measured by height. Which drug is producing more effect is measured by height. And from this graph, we can see the drug B is having the highest height. That means this one has maximum efficacy. This drug is having maximum efficacy. Okay, so this is what it is. So अब अपन एक mnemonic लिख लेते हैं. This mnemonic will help you remember things, and that is the help mnemonic. What is help? Height tells you efficacy. Height tells you efficacy, and left side tells you more potency. Okay, left side tells you more potency. So that's what you needed to know. HELP. ठीक है, ये तो याद हो गया सबको. Now, what is the second story that you need to learn as such in this, graphs? Now let me just point the same graph and show you the next side of the story. Guys, you must be knowing there is something called as competitive inhibition and non-competitive inhibition. Okay? Competitive inhibition and non-competitive inhibition. Now what is the story? Let's take the drug A was initially producing the effect at 5 mg. 5 mg pe it was producing effect. Yes or no? Assume antagonist drug has been given now. One more drug has been given who's fighting for the same site or something like that. That means competition has been created. Same thing, two guys are fighting to bind there, drug A and drug B. Now, if drug B is an antagonist, what happens now? How do I figure out if this is a competitive antagonist or a non-competitive antagonist? So, assume that after giving drug B, now, if I have to give more dose of the drug A from 5, I have to give 50 mg, right? This is the drug A, okay? So let's write here 5 mg per drug A. This is before antagonist. Before antagonist, 5 mg was producing the effect, whatever it is for me. But now after antagonist, I have to give how much dose? 50 mg. That means the dose requirement has increased, but I can still achieve the same effect. Yes or no? I'm still able to achieve same effect. This is called as competitive inhibition. This is called as competitive inhibition. What is dose also called as? Km. Dose is also called as Km. So can I say in competitive inhibition, you can achieve the same effect, but you just need to increase the dose. That's all is. So अब इसको क्या करना है? So if you want to remember, if you play the game right, if you play the game right, so सबसे पहले what is happening to this guy, it's moving towards right, okay, shifting towards the right side, yes or no? So that is the buzzword here. That means my graph will shift towards the right side. If you play the game right, you can win in competition, you can win competition. Now what is the second word we wanted to know here? This is competitive inhibition. By running more kilometers, by running more kilometers. So three buzzwords that I wanted you to know. That means in competitive inhibition, what is happening, doctors? The graph will move towards the right side. And if the graph is moving towards the right side, dose requirement is increasing. That means potency of the drug decreases in competitive inhibition. Earlier it was producing effect at 5 mg. Now same thing can be achieved, but you need to give 50 mg for this. Okay, that's that. Next, what is happening in non-competitive inhibition? The second graph would be for non-competitive inhibition. So imagine the same drug, okay, 5 mg pe, it was producing effect. This was the effect of drug A, and let's say this is before antagonist. Okay, this is before antagonist. After giving antagonist, if the same drug is looking like this, that means the effect have decreased. This antagonism is called as non-competitive antagonism. That means you increase the dose, decrease the dose, now nothing can be done, the effect will decrease. Antagonists have dominated this time, the effect have decreased. So can I say in this Vmax decreases? Vmax decreases in non-competitive antagonism. What is Vmax? Vmax is nothing but effect. Effect has decreased. So technically Vmax decreases, and what remains same? Km remains same. But what happened in competitive inhibition? In competitive inhibition, Km increases, but the Vmax remains same. That means I can still achieve the same effect, but I just need to increase the dose. So that's all. दो चीजें याद रखनी है. आप क्या करो? Memorize the statement I gave. If you play your game right, that means if the graph is moving towards right, you can win in competition. That means you're still able to achieve same effect, but you just have to increase the dose. ठीक है? So that's all. That was about this question, sir ji. चलिए. Next. Which of the following clinical trials is done for the first time in patients, and which one has maximum chances of drug failure? Which one has maximum chances of drug failure? All right, doctors. So the correct answer for this is phase 2. चलो देख लेते हैं इसको. Let's try to understand something here. So as you can see, there are multiple phases as such. Phase 1 till phase 4 is the most important that you guys need to know as such as doctors. But a new phase have also come in the update, that is phase 5 also. So let me just quickly explain all these things. First, phase 1 is basically done in those people who are, as such normal human volunteers. Okay, so both of these phases, phase 0 and phase 1, are done in normal people. Because it's a normal person, I cannot check if my drug is effective enough. For instance, let's say you made a drug for seizure treatment. How can you check if the drug works against seizure if the person doesn't even have a seizure? Right? So are you understanding this point? So technically, in the first phase, the only thing is we look for how much maximum dose I can give, maximum tolerable dose. So technically, I just want to check, is my drug toxic or not, right? What is more important when you're making the drug? First priority is the drug should not be toxic. It may be effective, not effective, that's the secondary thing. The drug should not be toxic. So first thing to check is when we start our clinical trials, we should check the toxicity which is tested in phase 1. So that's why it's called as human safety and pharmacological trials. Second thing is, this is the first one that is done in patients. This is the first phase to be done in patients. And because it's a patient, let's say I am checking a drug for seizure. I made a drug for seizure. Now I can check if the person is getting better or not. So this is to establish both efficacy as well as dose in the patients. Next, the same thing is to reconfirm. And this is the first time you're checking if your drug is effective or not. Now, so maximum chances of failure exist here. Maximum chances of failure exist. For the first time you're checking if your drug is actually effective or not. And this is where many people drugs will fail. If everything goes well, now we confirm efficacy in the phase 3, but in a very large group of population, right? And if everything goes well, then we file as such a request to FDA or CDSCO, right? And if they approve your drug, now we start using this drug in patients very commonly. This is why this is called as post-marketing surveillance. I've already started using my medications as such in people, and here's where I will come to know long-term or rare side effects. Okay, I will come to know long-term or rare side effects of drugs. And finally speaking, dear doctors, whatever we find in phase 4 will now be confirmed in phase 5. This is a new phase 5 called as pharmacoepidemiology. And if there is a new indication of a drug, I can check that. For example, sir, sildenafil is a drug that was made to treat pulmonary hypertension. Later, we found out that this drug is causing penile vasodilation. So I am also using it for erectile dysfunction now. That means it's a new use of the same drug. I didn't make my drug for erectile dysfunction. Later, I'm using it. So those new indications we are going to learn in phase 5. So that's all. This is our next thing. Okay. Now, last few questions. We are coming to chemotherapy aspects, and this will be our last parts of pharmacology discussion. So guys, a blood smear of a patient who has been on an antibiotic for a while has been shown in the image. Administration of what along with antibiotic could have prevented this condition? Okay? I know if I give you this question straightforward, most of you would have answered. Thoda sa integration. Let's learn it this way, right? So let's go. First thing, what has been given to you in this part, you have to identify, sir. Okay. Now, it's all right if we get it wrong. I don't mind that. Let's learn. Sir, I will give you the word first of all. This is nothing but sideroblastic anemia. Sideroblastic anemia. Okay. And sideroblastic anemia, you have to remember, it happens due to decrease in vitamin B6. Okay, it happens due to decrease in vitamin B6. What is vitamin B6 called as? Pyridoxine. And now you should ask a question, which antibiotic causes this very commonly? It's a very important question, sir. That's why we are discussing this. One of the TB drugs called as isoniazid. Isoniazid is a TB drug that decreases vitamin B6 and it causes what? Sideroblastic anemia. It causes sideroblastic anemia. Basically, if you don't want this to happen or if you want to treat it, you have to give vitamin B6. And what is vitamin B6? Pyridoxine. So basically, you have to give pyridoxine. Okay, so that's that. Thiamine is given to which people? Alcoholic people. Remember, thiamine deficiency is seen in alcoholics, so you should give thiamine in them. Folate is generally given to pregnant people because folate deficiency happens in pregnancy leading to neural tube defects. वैसे ही इसको भी रट लो सर. Please make sure you know pyridoxine deficiency. It is seen with isoniazid, which is a TB drug. That's why isoniazid you should always give with this thing, that is pyridoxine. Now, this would be just a quick recap of important side effects you should be knowing of these 4 TB drugs that I've just jotted it down for you. Please read this later on. Now, I'm just going to discuss this important side effects, individual side effects by different antibiotics. For instance, let's begin here. Red man syndrome. Red man syndrome. This is due to one antibiotic called as vancomycin. Okay, vancomycin. This is the one that does it, and it does it because it releases histamine. Histamine release causes vasodilation, and that vasodilation causes redness called as red man syndrome. Next, gray baby syndrome and bone marrow suppression. It is seen by an antibiotic called as chloramphenicol. These are just buzzwords, doctor, right? Easy ones. Chloramphenicol. Disulfiram-like reaction. It is seen with cephalosporins. And one more you should know is metronidazole. That means if somebody is taking this antibiotics, they should not drink alcohol that time. Otherwise, they will feel, as such very, very sick. Teeth damage and bone damage is by drugs called as tetracyclines. Tetracyclines are those drugs that end with cyclin. Doxycycline example is tetracycline. Cartilage and tendon damage. This is seen with drugs called as fluoroquinolones, which are none other than your fluoxetins. Fluoxetins causes tendon and cartilage damage. Next, Cernecterus and SLE. It is seen by sulfonamides. Once again, a good reminder to all of you, there was a mnemonic called as shift. Please do revise it quickly, right? S for sulfonamides in the SLE. Nephro and ototoxic drugs are drugs what we call as aminoglycosides. Aminoglycosides. And doctors, let's remember NO for nephro and ototoxic drugs. Aminoglycosides are these ones. Okay? So that's all that you needed to know. Chalo, this one is easy. I want you to pick the answer quickly as possible. Okay. All right. It's like a streak of correct answers and wrong answers. Both are coming up. See, first of all, sir, diabetes is mentioned, COVID is mentioned, black color area is mentioned, near the eyes, nose. What else do you need? Mucormycosis. Mucormycosis. That has been mentioned. Done. How do you know? Connect it to your microbiology, sir. Right? As you know, in mucormycosis, how are the septae? Right? The septae, I mean, as such, these are hyphae. These are hyphae picture that is given. How are these hyphae? They are not having any gaps in between, so they're called as aseptate. Aseptate. If you're having linings, that is called as septate hyphae. Okay, this is your aseptate hyphae, first of all. Okay, and they are branching at 90-degree angle. 90-degree angle, that's how they branch. So that tells me this is mucor. Okay, next, aspergillus, as a comparison I will teach you right here. Aspergillus, another fungus. The hyphae are septate and they branch at 45 degree. This is 90 degree. This is 45 degree. Think of it. And the hint you have to remember is like this, doctors. See, A for aspergillus now. This is the A. Imagine this is your A right now. And turn it around like this. The same A, turn it around. You get a 45-degree angle right now. 45 degree. And if you look at your fingers, they are having septae. That means this will become 45-degree angle. This is our mnemonic. And last one, what is the drug to be given? Turn around like this. This becomes your next drug called as voriconazole. Voriconazole surgery. So technically you have A for aspergillus, 45-degree angle with septae, and voriconazole for aspergillus. And now for mucormycosis, I did not ask you what is the drug of choice. Please read questions properly, that's why. Right? I asked which one is not used except. Answer is ketoconazole. Ketoconazole is not used. Who is used? PIA. Right? Who's used in this? PIA. And who's the drug of choice? Amphotericin B. Right? So that's what you need to know. PIA is the word here. Amphotericin B is the drug of choice for mucormycosis. ठीक है, चलिए सर, that integration also done. Last is anti-cancer के बारे में कुछ. Let us learn one or two things. A 50-year-old obese man with history of smoking and drinking alcohol presented to the gastro department with complaints of frequent heartburn and regurgitation of stomach contents and dysphagia. Endoscopy revealed columnar metaplasia, Barrett's esophagus basically, and later neoplastic changes were found. The patient was prescribed cisplatin for the treatment, during which the patient developed nausea, vomiting. See, this is my advice to all of you. Always read the last one or two lines of questions. A lot of time, the main question is hidden in the last one or two lines. Upper parts may be distraction. But anyway, nothing goes waste. Columnar metaplasia, this is Barrett's. Probably this guy developed esophageal cancer. He was given a drug called as cisplatin because cisplatin is one of the widest spectrum drug. It's used in almost all cancers, right? And what is one very common side effect of anti-cancer drugs? They cause vomiting. And the drug of choice for those vomiting is what? Cetrons. Cetrons. So basically, what is the drug to be given here? Cetron is the correct answer. Okay. Next, check it out here. Chemo-induced nausea, vomiting is called as CINV. Early onset means after starting anti-cancer drugs, if the vomiting happens within 24 hours, then the better drug would be ondansetron. Ondansetron. Okay. They are 5-HT3 blockers, the drug of choice overall. And in your exam, 90% this is what is going to be questioned. So, these cetrons are not only the drug of choice for chemo, but they are also the drug of choice for radiation-induced vomiting also. chemo and radio, both vomitings are treated by same drug called as ondansetron. Late onset means you can use palonocitron. Why? Because it's a long acting drug. Okay, palonocitron can be used in even late onset, but the drug of choice is the drugs called as patent drugs. NK1 blockers called as patent drugs are the drug of choice for late onset vomiting. Late onset means after 24 hours. Okay, so that is that. What are other side effects of anti-cancer drugs? They cause bone marrow suppression. Now, bone marrow suppression means RBCs are decreased by anti-cancer drugs, WBCs are decreased by them, platelets are decreased by them. I want to increase them. And second, there is something called as tumor lysis syndrome, which increases uric acid in patients. So for uric acid, we have already learned drugs like allopurinol or rasburicase. This is all happening due to cancer treatment. So how to increase RBC? Simple सी बात है, give erythropoietin to them. Erythropoietin. Okay, erythro is RBC. Next, WBC, how to increase? Give them this factor called as GM-CSF, granulocyte monocyte colony stimulating factor, and the drug here is known as sargramostim. This is the medication you need to know, sargramostim. What is sargramostim? Stim means stimulation. Kiska stimulation? Monocyte. GRA for granulocyte. Granulocyte monocyte stimulation is called as sargramostim. There's one more drug called as filgrastim. Filgrastim, if you see here, there is stim, but there is only grastim. That means it's only granulocyte stimulation. Gramostim is granulocyte monocyte stimulation. Filgrastim is only granulocyte stimulation. Either way, these drugs can increase your WBC. Last, to increase platelets, we need one signal called as interleukin 11. We need interleukin 11, and the drug that stimulates interleukin 11, it is called by the name of oprelvecin. Oprelvecin. Now, I have added one letter to this drug which will help you remember this drug more easily. Okay, oprelvecin. This is the name of drug. And now, if you notice, 11 interleukin. You can see within the name of drug, 11 interleukin drug is called as oprelvecin. It's for increasing platelets. So, khatam. Commonest side effect of anti-cancer drugs are nausea, vomiting, and some drugs can cause bone marrow suppression. How to treat that bone marrow suppression we have learned. And one more thing, anti-cancer treatment can cause hyperuricemia. How to treat that is also written, that is allopurinol and rasburicase. Now, some specific side effects and their antidotes, as such, that you needed to know, guys. So please know, hemorrhagic cystitis and SIADH, it is caused by a drug called as cyclophosphamide. Cyclophosphamide. This is the drug that can cause this. Okay. And this side effects are treated by an antidote called as Mesna. Okay. This is your Mesna. Is that understood? This is the antidote. Please don't get me wrong. Cyclophosphamide causes hemorrhagic cystitis, and that is treated by an antidote called as Mesna. Okay. Pulmonary fibrosis can be caused by multiple drugs, but at least remember busulfan and bleomycin. Flagellate dermatitis, almost like tiger-like skin. Tiger-like skin is again caused by the drug called as bleomycin. Okay. Dilated cardiomyopathy. It's caused by drugs called as doxo or donorubicin. Doxo or donorubicin. Okay. And the antidote is dexrazoxane. Antidote is called by the name of dexrazoxane. Right? So ये anti-cancer के main side effects है. Please remember most likely we can answer the exam question which should be asked from this. What is the most emetogenic drug? Cisplatin, what we just studied. Cisplatin is the most emetogenic drug, and the same drug is also nephro and ototoxic. Nephro and ototoxic. So this nephrotoxicity, what do you need to know, is basically treated by antidote called as amifostin. And one more thing we do as prevention, it's not a treatment, it's a prevention. We do something called as mannitol plus chloride diuresis. Mannitol plus chloride diuresis. You have to give fluids to the patient and remove as much as we can. As such, right? That is what is done to prevent that nephrotoxicity of cisplatin. Megaloblastic anemia. Megaloblastic anemia means most probably this drug is decreasing vitamin B12. That's why this must be happening. Sorry, it must be decreasing folate. Okay. This drug must be decreasing folate, because of which it's causing megaloblastic anemia. And that drug is methotrexate. Methotrexate, it causes this. Okay, megaloblastic anemia. And the treatment is nothing to give them but folic acid. We have to give them folic acid. We just give them folic acid, and it's given one name you must have all studied, leucovorin rescue. We call it as leucovorin rescue. Okay, so as such, these are the things that we needed to know. Bone marrow suppression, one more drug if you want to remember, it is vinblastine. Vinblastine. It blasts the bone marrow. Okay, vinblastine blast the bone marrow. That's it. These are some important side effects I've given you that you should know along with their antidotes, and most questions are expected from here, sir. Last topic of our discussion for today, radiosensitizer drugs. So first question is, why are radiosensitizers given as such? Okay, so what are these drugs? As I have put down, these are the drugs. Okay, radiosensitizer, as the name says, they sensitize our cells, especially cancer cells, to radiation. Now try to understand this. Guys, let's say there is a solitary tumor somewhere in the body. I can remove that tumor by surgery, right? I can remove that tumor by doing surgery. If you talk head, very complicated structure, GIT, very complicated structure. So many structures are there. How many structures can you remove by surgery? So understand the point. What do we want to do in such cancers, especially head and neck cancer or GIT cancer, is give those treatments like chemotherapy and radiation. Now, if you're giving radiation to the patient, you want cancer cells to die more easily. That means you want to sensitize the cancer cells to our drugs. So which drugs make the cancer cells more sensitive so that they can easily die? These are the drugs. This is the list. But from this, top drugs which are used as such, you may be seeing, right, in head and neck cancers or this GIT cancers, etc. These are drugs like cisplatin or 5-FU, etc. So as such, see, why did I put radio? Radio says sare gamma pa, we have to remember. But sare gamma pa does not work in medicine. As you know, in most subjects of medicine, the mnemonic is ABCD, unfortunately. So at least yaad aayega, radio dekh ke, radio sensitizer, it's ABCDEFG, right? So you have to sing this. These are the drugs. Top drugs are which ones? Cisplatin and 5-FU. They make the cancer cells more sensitive to radiation. That's how we can treat them more easily. Okay, so that's it. Last and the final, thank you very much for holding on, and you guys did very well. As such, intentionally, there was a reason I wanted you to learn difficult questions also, right? It's not like I want to make you feel bad or anything. It's just we are learning concepts, right? We are opening our eyes now how to answer more MCQs if they come in those fashions. See, what you know, you already know. There's nothing, useful just sitting here for 2 hours and just answering the things what you already know, right? This session was to learn things, and hopefully, right, I was able to deliver some things which has, opened your eyes and helped you as such. And that's it from me, my dear friends. As I told you, if you have any other questions, etc., please message me on Instagram. My ID I have just given up there. And many of you were asking me even microbiology. So please just do me a favor for microbiology. Just watch my previous videos, and most of them, the important aspects would be covered in those videos itself. Okay, so the last videos, just type Dr. Salman microbiology as such in the Miss channel. You're going to find my previous videos as well. Please just watch them. They are good enough. You will be getting the most important things from that itself. So that's it from my side. It was great to be at your service. Thank you very much, everybody. Take care. And last but not the least, when the exam is over, please do help me with the recall questions. Please help me write down what questions came, how they came. I'll be waiting for that. And the next time you message me is when the result comes that I have passed. And guys, I am hoping that you guys pass this exam with the flying colors, as they say. Okay. Last one thing I would want to say and go. Okay, I did not use Hindi for one reason in the class, because everybody needs to know things. That's why I was not saying anything else. एक चीज याद रख लो, बंदे की अगर कहानी सोचो तो उम्मीदों से ही घायल है और उम्मीदों पे ही जिंदा है. Right? Please remember this line, what I said. That means we should never lose hope. Hope is something that has brought us till here, and hope is something that will take us forward also. ठीक है?